Firstly, thank you very much for inviting me here. I'd like to thank the three chairs for asking me to come here. I've been coming quite a few years, but obviously during the COVID era, I was just on the screen. I hope you find me more attractive in person. So I really enjoyed the debate during the Merck Symposium about metabolic issues and drugs. So I'm going to talk today about what can you do about these comorbidities in terms of managing them, and should you be doing primary prevention? So there are my disclosures. Now, these are the things you can do, right? It's the A, B, C, D. You know, everyone likes these lists, but here they are. But under C, I put choose your antiretrovirals, okay? Because we're going to be talking about, if you do something with antivirals, can you improve the patient's comorbidities? Okay, but what could we prevent? Now, one word in English you'll now have to know is MACE. I had to know, I saw this word MACE. I said, what's MACE? It's major adverse cardiovascular events, right? And people will be talking about that for the next few years because of the REPRIEVE study. I'm going to talk about that at the end. So here they are, the commonest events that we see. Ischemic heart disease, right? Ischemic stroke. And people are much more worried now, especially men, about stroke than they're about a heart attack. Because you have a heart attack, get a stent. You have a stroke, you have to get a frame or a, whatever. So it's much more difficult. Okay, and if you look at this, in the green and the blue line, these are people with inflammation and people from the general population. Cardiovascular disease has been coming down. Whereas in the red line, in our HIV group here, if this works well, in the red line, you can see it's been going up. And this has been the global burden of cardiovascular disease in HIV all the way from 1990, when we got therapy about 97. It has been going up, and you're in the sort of second tier down. That orange color is Latin America. So we are seeing a global burden causing disability. But what can we modify? Now, if we were back in 1990, they're almost the same as 2019. But there's one thing that's becoming more important to control to modify cardiovascular problems, the MACE problems, and that is high body mass index, people getting big. I will note on there air pollution that people don't realize how serious that is in terms of cardiovascular risk, but it's high body mass index. So we've had lots of pandemics going on, but for 40 years, we've had a pandemic that we've hardly touched. We've hardly thought about, because every time we sit down and eat, it's a good feeling, huh? And it's increased 3 times in over 40 years, the amount of obesity, right? So, and in the world, about 11% of men and 15% of females, and this data is now 8 years old, right, are obese. Now, why is obesity important? Because high blood pressure is twice as common. Number of people with diabetes has increased by 60% in the last 10 years, mainly related to obesity. 4 million deaths every year due to overweight, obesity-related cardiovascular disease. And every increase in BMI of 5 increases your risk of death by 30%. Now look, cigarette smoking is pretty serious, but what about BMI going up by that, right? That's pretty serious too, but we're not doing much about it. So it's common in HIV, and you can see here, especially in low and middle income countries. Everybody thinks it's in the rich, but it's not. Low and middle income countries are becoming overweight and obese, okay, about 27% from this study. But what can you do? So we heard about these cases, and we always have these cases where people say, I've got a patient coming in and they're complaining of weight gain. Okay, so when all the stuff happened about integrase and TAF, everybody reached for their prescription pad, cut off the integrase and TAF and gave something different. But hang on a minute, let's just think about being people gaining weight. This is one thing to tell people: stop eating ultra-processed food. It causes myocardial infarctions, it causes blood pressure, it causes stroke. How many conferences have you been at where you've walked outside? Sorry, you've walked outside and that stuff is there in front of you to eat, right? It should stop today. People who are younger, poorer, or from disadvantaged areas, HIV patients, often from there, right? People with HIV can have a diet comprising as much as 80% of ultra-processed food. And a Brazilian, Fernando Halba, said most UPF is not food, it's an industrially produced edible substance. So please, please think about what you're eating and what you're asking your patients to eat. So what can you do? Yeah, okay, let's go to the gym, let's eat less, okay, let's go on a diet. So these two plans here, I don't know if this point, it sort of washes out on there, it doesn't matter. So if you do nothing, all right, the top one there, males and females, if you do nothing, the purple and blue line just goes flat. But if you do everything, if you reduce your calories, right, if you go on a specific diet and you increase your activity, you can see you will lose weight. It's obvious, we know that. And also, depending on your age, whether you're young or older, you'll still lose weight, right? So there you go. What you have to tell people is don't eat junk food, reduce the amount of calories, increase your physical activity. But we've known that for years, okay? And it doesn't seem to be working very well. So what do we do? I'll tell you what we do. We invent a medicine that makes you lose weight so you can eat as much as you like. You can lie on the couch watching Netflix and inject something in your belly once a week, which is great. For lots of people who find it very difficult to lose weight, it's great. But I'm just making the example about how human beings behave when we're faced with a problem. Let's invent a medicine. So here's the way, it's a great drug, semaglutide, it's expensive, it's not everywhere, but that now because so many people are using it, guess what? We're having reports around the world of depression, suicidality, pancreatitis, gastroparesis. That's because so many people are on it now that people are reporting side effects they didn't see in the trial. So you can give people this. I'm all for it. I think it's fantastic, especially if it's put with a new lifestyle for the patient so they can see they're losing weight and you can adapt them to, hey, you're eating less, try and keep to that, do some more exercise. So it is a good thing to get people motivated, I think, who have tried everything in the past. And here's some data from HIV, just in case you thought there wasn't any, there is. The body weight change is about 8% at week 32. You'd expect it to probably be about 15% by just over a year. And you can see about this decrease in that, and it's very well tolerated. So there we go. Now, what about drugs? The first thing to do is look at the other drugs patients are on before you get to the antiretrovirals, because all these other drugs are associated with weight gain. And I remember a Swiss guy saying to me, the psychiatric hospital phoned me yesterday and they told me about a patient who's on dolutegravir and they put on 10 kilos on weight and I've told them to stop it immediately. I said, but what else have they given them? Oh, risperidone, clozapine, quietapine, etc. Right? So I'm going, hang on, there are other reasons. So other drugs. Now, I know people say TAF and instis make you put on weight. They don't make you put on weight. They are associated with weight gain. And in my eyes, and in lots of people now, you'll see this a lot, they're associated with normal weight gain. An American, a US person, puts on 0.5 to 1 kilo every year in weight in their middle ages, right? So that's a lot of weight. And if you just look at this data, these are HIV negatives and HIV positives. Look at IPREX. If you look at the left-hand column here, you can see that people given TDF, they don't gain weight. In fact, they're losing a bit. They should have gained 1 kilo, like the placebo people. Look at the Discover, TDF versus a TAF. In that TDF, they didn't gain weight, but the TAF people did. So TAF makes you gain weight? No, TAF is like the placebo. You're just gaining weight as normal. Look at cabotegravir versus placebo. Same amount of weight gain. But look at cabotegravir versus TDF. TDF didn't make you gain weight. So TDF and efavirenz especially are weight suppressant drugs. And there's lots of data, historical data showing the old ARVs prevent you from gaining normal weight, whereas the newer drugs are absolutely neutral. Now, you don't have to believe me. It's just if you look at all the data, this is where it's come to. So if you really thought that integrases and TAF made you put on weight, then stopping them should make you lose weight, perhaps. But when you look at this, this is the advanced study, the big study on weight gain. When you switched off, right, TAF, FTC to DTG, and you switched to, instead of TAF, you switched to TDF, the only people that lost a bit of weight were the females. Nobody else really lost weight, okay? And now the interesting thing is, look at the people on efavirenz, what happened to them when they switched to TLD and they came off the efavirenz, which was suppressing their weight, they went back to normal weight gain. So switching off the drugs isn't going to do very much for you. And here's another one. Here now, they said, right, you're on an integrase inhibitor, we're going to switch you to a boosted PI because you've been gaining weight. So these people had gained about 8 kilos. Well, if you look at the blue line, which is darunavir with cobicistat and TAF, you can see they actually gained weight more than the people who were kept on their integrases. Okay, so there you go. I mean, it's really interesting that trying to switch drugs at the moment for people who gain weight isn't going to do very much for you. Because actually, if you're on an integrase and on TAF, you're just going to gain weight like you would normally if you're HIV negative year by year. So you should exercise, you should restrict your calories, okay, and maybe go on semaglutide to get the boost. But switching antiretrovirals, the risk is you'll get new side effects and you'll get virological failure. So be very careful about thinking about switching someone who's stable. Diabetes, right? Diabetes, another comorbidity. Shall we switch drugs? Well, who's at risk? HIV patients are just at risk as everybody else of diabetes if all these things happen. And 4 out of 5 people with diabetes live in low and middle income countries. So this is where the big problem is. And of course, where do most people with HIV on therapy live? They live in low and middle income countries. So if you put the two together, you have a problem. Now, up until 2012, there was no difference in the incidence of diabetes in people with and without HIV from this big Danish study. There was no association whatsoever. And then suddenly, in the integrase era, we saw some changes and we saw some studies saying, hey, integrases are associated with diabetes. Well, maybe they are. But then other big studies showed there's no significant increase. So we were left with a puzzle. Some studies showed it does, and some studies showed it didn't. And then these people came along, and they said there's an increase in diabetes with weight gain. And we knew that anyway. So if you're on a therapy that's neutral to weight and your weight just gains normally, and there's an epidemic of a pandemic of obesity in the world, and you're becoming one of the obese people like people who are not on HIV drugs, what's going to happen? You're going to increase the risk of diabetes. Okay. So then they said, then another group said, well, is it all weight gain? And this group, the Respond group, they have said this. They have said, perhaps integrases have got some activity more than just putting on weight to cause diabetes. And you can see in the blue, instis seem to have had more effect on diabetes, on the risk, compared with no instis. But the problem with these, this big cohort is, it's a cohort analysis, there's lots of data missing, unfortunately, and they used just the BMI. They haven't used weight gain per year. And I'll show you why that's important later. And the same group also showed, hang on a minute, integrases also cause cardiovascular disease, but you can see it's only in the first 6 months. Then it disappears again at a year. Oh, it comes back again at 18 months, and then it disappears again. Now, this must be all confounding and biases. How can you believe that a drug will cause increased risk of cardiovascular disease at 6 months? At a year, it disappears and it comes back again at 12 months and then disappears again at 2 years. Okay, so there's a problem with the analysis in my eyes, because when the Swiss looked at all of the data on their cardiovascular risk, and they used a different analysis, right, which is very interesting. They run it more like a clinical trial. They found no risk of cardiovascular disease with integrases. So far, we've got weight gain and integrases. I don't believe it, right? I don't think they cause weight gain. I just think they're neutral. We've seen diabetes. Maybe there's some additive effect of integrase. I don't believe it. I think it's related to weight gain and the analysis they did. We've seen cardiovascular disease, but when the Swiss do an analysis on theirs, you can see it disappears. There's no risk of cardiovascular disease and integrase. It seems to be separate. We've now moved to hypertension, right? So now everybody's worried about hypertension and integrases. You can see how all these comorbidities, everybody's examining them. So you look at NAMSAL and ADVANCE. It is true that in both of those, you can see the definitions of blood pressure are different in both. Okay, one's 140/90, one's 130/85. There's a problem. But you can see in both it tends to be increasing over time. But they've said their initial analysis suggests the blood pressure increase is because of weight gain, not because of the drug. So when you see the other data, you start to get a bit concerned. Now, 4 clinical trials, randomized clinical trials, have found no effects of integrases and blood pressure. But human beings, as we are, we like to believe in the rumor, in the other stuff. So let me show you the rumor now, right? So here's the rumor that came out in the IAS that integrases and TAF cause blood pressure. If you put BMI in there, then the BMI makes the risk a bit less, right? So there you go, risk of hypertension. And everyone's going, what's going on? Randomized trials have not shown it, and yet this group have, okay. But they use BMI. And in fact, if you look at this massive study on hypertension and parameters that predict it, BMI is not so good. Much better to look at weight gain per year. So what those guys who've shown a correlation between integrases and hypertension should do is use that in the analysis. I actually told them to do it at AIS. And they should also use the Swiss analysis where they try and run it like a clinical trial to see if they still get the same data. Why do I say that? Because lots of people are going to read it and go, oh, you've got hypertension. I've got to take you off your integrase. You are a borderline hypertensive. I'm not going to give you an integrase and TAF, which is fine. You don't have to because there are alternatives. But I think that we did it with pregnancy. People are doing it with cardiovascular disease. We're doing it with all sorts of things. We have to look at the data more carefully. Now, finally, I'm going to talk about lipids. Firstly, TDF is a fantastic anti-lipid drug, and now that nobody's using it for that, why don't they do it and give it to people to lower their lipids? Well, because there are probably stronger drugs, but it's an anti-lipid drug. We've known that. And I've just put here that boosted PIs are probably the worst for your lipids overall. Now, we did a study of switching drugs, NEAT22. We stopped people's PIs and we gave them dolutegravir, and it did all the blue, all the improvement you can see in the lipids. And when you look at the far right, the total cholesterol to HDL ratio, we did make an improvement in that. We did make an improvement in percent, but actually clinically, it's not very much. A decrease in your ratio by 7% is small, but we did see it. And anything, that can improve your lipids has got to be good. Now, if you switch to dolutegravir 3-TC, what happens to your lipids? Well, you can see here, it's a little improvement compared with if you stay on TAF, right? But if you look at the total cholesterol to HDL ratio, it's not much at all. And in SALSA, if you look at this, where you come from any 3-drug regimen and go to dolutegravir 3-TC, what happens is you lose the effect of TDF, and actually things can go the other way. So I don't think that any of these things really massively impact your lipids. And I'm not sure it's really worth switching people off a regimen that they're undetectable on and they're doing really well and they're tolerating on just for the small impact on lipids you might see. Okay, what should you do? Well, I think you should use a statin. And why? I didn't think this until July of this year. Even if people are low risk, you should use a statin in HIV to prevent MACE. Remember what MACE is? Major adverse cardiovascular events. Right, there we go. So why is that? And it's because we know cardiovascular risk is elevated up to twice that of the general population, and statins have an effect, right, beyond lowering LDL, and they have an anti-inflammatory effect, many statins. And that is why it's important when you look at this data, the reprieve data, you should look at the women, because women have more inflammation than men. And therefore, statins may be helping women through reducing inflammation, not just by reducing their LDL. So here's some data here to show that statins reduce inflammation. Here's placebo versus rosuvastatin and the CRP. The CRP is less. Why should, that's interesting, isn't it? Rosuvastatin lowers your CRP, which is good because you don't want inflammation going on. This is from the Jupiter study. Here's in HIV, and here we've got rosuvastatin in the red, right, reducing all these inflammatory markers. Again, a statin not only lowering LDL, but also reducing levels of inflammation. Why is that important? It's because of this study Reprieve, where you're HIV positive, you've got a CD4 more than 100, and you're between 40 and 75 years old, which is the big window for cardiovascular disease, right? That's when you get it. They didn't have any, they were asymptomatic, they didn't have any atherosclerotic disease. And they took everybody with these 10-year scores, this American Society Cardiovascular Risk Score, right? They had them all in there and they divided them up. Okay, so what was the objective? This looks complicated, but all it said was, we randomize you to give you a placebo or we'll give you pivastatin. Pitavastatin, 4 milligrams a day, and we're just going to measure how many MACE events you get. So that's the basic thing. And then there's lots of secondary endpoints that they haven't done. Why pitavastatin? Because it's a moderate intensity lowering of LDL. It's got anti-inflammatory effects. It doesn't interact with antiretrovirals, and on glucose metabolism, it doesn't do very much. The problem is it's not available everywhere, right? But I'll talk about that. Now, whenever people say to you, I don't believe that Reprieve study, just think of this, right? After 5 years, the study was stopped by the DSMB. Now, a study to be stopped must mean there's a significant difference between the placebo arm and the active arm for them to actually say, halt, right? Halt. Here are the results. A 35% decrease in cardiovascular events. Now, that's big, right? That's big. 35% decrease. I mean, most of us would go for that. And in terms of saying, wow, is this worth giving someone a drug? Now, I'm not saying it's for everybody, because there are some little things we need to know. Right, so who did it most benefit? And if you look here, if you look at the ACE-SCVD risk score on the left here, you can see the biggest benefit was those between 5 to 10%. So if you're going to give it, people over 10% anyway will get statins, and why the confidence intervals crossed over because there weren't so many. But those people with a 5 to 10% risk, you can see they had a big benefit. And what about side effects? They were quite small, but people are talking about them. But rhabdomyolysis wasn't very big, and nor was diabetes, not more than usual. So who benefits from Reprieve? It's those with a cardiovascular risk score of greater than 5. Now, we don't usually give it statins to people with a risk factor of 5, right? It's usually over 10, and some guidelines are 15%. So, but interestingly, if you had hypertension, they didn't seem to work so much, or with current smokers. I don't know why, but anyway, those are usually populations. You've got low threshold to put on a statin anyway, but it's interesting. So, how many patients do you need to treat to prevent one event? Well, if you look there, if you've got a cardiovascular risk of more than 10, you only have to put 35 people on. But the group that I'm talking about, the risk factors of 5 to 10%, it's 53. If you look on the right there, antihypertensive treatment, right? We give that to anybody who's hypertensive, but the number needed to treat is 100. Aspirin is probably not worthwhile. And in the Jupiter statin trial, the 5-year was 57, which is very similar to the 5 to 10% we see here. Okay. What they will tell you, if you use all of the risk scores, the overall was to treat 106 patients. But if you just look at that 5 to 10% risk, it's 53. So where does that put you with guidelines? So here we are. Number needed to treat, okay, reprieve anybody with more than 5%. But then if you've got less than 5%, you wouldn't really, I wouldn't consider at all to start them on a statin. There we go. So this is quite nice here. Red, absolutely. Yellow there, consider it, and don't consider in the green. What about side effects? So muscle-related symptoms, not much higher than placebo. Diabetes, we know that all statins increase the risk of diabetes by 1%. All of them do, okay? And then I read in the press this, some African doctors say we don't want to give it because for every person for every case of myocardial infarction prevented by pitavastatin, there are 5 cases of diabetes. That is not true. That is not true. But this is people looking at the data and making calculations. So I decided I'd do a calculation, right? The incidence of diabetes in placebo was 4%. The incidence on pitavastatin was 5%. The usual 1% increase in statins. My own calculation was the number needed to harm from statins was 77, and other statins is about 60, you can see. And all right, and actually the statins protected the diabetics as well as they did as everybody else. So here's some other study. Basically, you have to treat 255 people for 4 years with a statin to get 1 extra case of diabetes, okay? 1 extra case. And obviously, if you've got a high fasting glucose, you're obese, you're hypertensive, high fasting triglycerides, you're more likely to develop diabetes with the statin. So it comes to that question, should we use pitavastatin in everybody? Well, based on the data, yes. But if you can't get it, what should you use? Well, we'll use atorvastatin, but rosuvastatin as well could be used. Okay, but I don't think it's going to be impossible to do this study again with every single statin that's ever existed. But I would be very confident that these statins also are useful. Who's going to do it? Are you going to do it in the clinic? ID physicians? You're going to start giving it? General internists, family doctors. But I also think one thing that's come out of Reprieve, if your risk is 4.5%, right, and you're coming every 6 months getting older, soon your risk is going to be 50%. So start having the conversation early. You don't have to start the statin, but have the conversation early before they get a surprise, right? So that's what I think. And what do the guidelines say? I heard people talking, what should we do? The British HIV Association already have guidelines about talking to people about going on a statin if their risk is more than 5%. What do you do in continents like Latin America or Africa? Do you have everybody going on the statin? Do you all say atorvastatin's the cheapest? Do you all try and get pitavastatin because it's now become generic? What do you do, right? Who's going to pay for all this? And we already heard from Carlo about individualized therapy in high-income countries will continue.